A heartfelt welcome to everybody that's here in the audience and with us online. I'm Steve Higgins, the director of the Vermont Center on Behavior and Health. And I want to thank you for joining us for the April lecture in our monthly lecture series. And we are going to have a good one. As you can see, we have Karen Cropsey with us, and she's going to be talking about tobacco disparities and cessation strategies in vulnerable populations, which are topics that are, really close to what we do in a VCBH, and in vulnerable populations, which is something we also focus on. So we really happy that Karen is here to share her knowledge with us. And I'm going to have Eli Klemper, Associate Director of the VCBH, come up and do a more detailed introduction of Karen, because Eli and Karen share interest in addictions in the incarcerated population, very important, vulnerable population. So Eli?
So it's my pleasure to introduce and welcome Dr. Karen Cropsey as our guest lecturer today. Dr. Cropsey is a tenured professor of psychiatry and behavioral neurobiology at the University of Alabama at Birmingham School of Medicine, where she is an endowed chair in psychiatric research and serves as director of the Center for Addiction and Pain Prevention and Intervention, which is a university-wide interdisciplinary research center. And Dr. Cropsey is an internationally recognized a scholar for her research on tobacco use and cessation among populations that experience some of the largest and most persistent health disparities in the U.S. and abroad, including individuals involved in the criminal legal system, people with HIV, low-income communities, and racial and ethnically marginalized populations. Over the course of her career, she has led or collaborated on numerous NIH-funded clinical trials, many of them focused on developing and testing innovative and pragmatic, as well as scalable cessation strategies in real-world settings. Her work has made particularly important contributions to advancing how our field thinks about tailoring tobacco treatment to individual needs and structural considerations. And, I had the opportunity to look over Karen's CV last night preparing for this, and was just struck because I'm focused on tobacco work primarily, but I think I could get up here and say the same thing about her work in opioids and alcohol. So the breadth is just really impressive. All in all, across more than 200 peer-reviewed publications, her research has shaped our understanding of how social context, comorbid conditions, and structural inequalities influence tobacco dependence and quit success. So today, Karen Cropsey will be giving her talk entitled Targeting Tobacco Disparities, Innovative Cessation Strategies for Vulnerable Populations. Karen.
Well, thank you, everyone. Really appreciate the invitation to come today and to speak with you about my work. I'm really delighted to be at Vermont. I think the last time I was here, I went skiing in Killington. So not able to go skiing, although I hear they're still open, the ski resorts. But really just delighted to be here and to meet with you all. So I'm going to start with some things that we already know. We know that cigarette use remains a prevalent condition within the United States and continues to be the leading cause of death and disability, and results in death in 50% of people who use tobacco and who smoke. We have some good news, though. In 2024, the latest prevalence rates for cigarette smoking dropped below 10, which is the first time it's ever been below 10. And we do know as well that smoking disproportionately is concentrated in disadvantaged groups, such as people with substance use disorders, people low SES, people with mental illness, and then people with structural disadvantage, people in the criminal justice system, the homeless population. And when you look across all these different sort of marginalized groups, you see that about 55 to 65% of people who smoke are members of one of these groups. So over the course of my career, when I think about my tobacco work, I like to think of it in kind of these three different main areas that I focused on: the criminal legal system and tobacco use, HIV and infectious diseases, and then a more recent area, which is in sleep and circadian rhythms and tobacco. And I'm going to talk about each of those today. So I'm going to start where I started, which is in the criminal legal system and working with people within this population. So I became interested in this population when I was in graduate school, actually really before I went to college. I think I was watching too much Law and Order and legal shows. And so I wanted to be a criminal justice attorney and be a defense attorney. I was always very struck by just the vulnerability of this population and just the high need of this population. And then when I went to graduate school, I had this opportunity to do a rotation and do work within the criminal legal system, and went and worked in a male prison. And again, really loved working with that population. Again, the need and really the gratefulness of the population and working on mental health issues and substance use is really what drew me to the population. But then I was really struck by the high rates of smoking in this population. So again, as we know, about 70% of people in the general population want to quit smoking. And I think there's a belief that within the criminal justice population, they're not interested in quitting smoking. And I would say that is not true at all. And when I've given surveys of people in the criminal justice system, about the same percent want to quit smoking. So I don't think there's much difference there. But we do know that our smoking cessation interventions, even in the general population, only result in about 15 to 25% of cessation at 6 months. One of the things that I've also been struck with my career is how important adherence to both behavioral, but also cessation pharmacotherapy is in increasing quit rates. And you see a tripling of quit rates when people are adherent to their medications. Now, many of you may not understand or know as much about the criminal legal system. And in the United States, we incarcerate more people than any other country in the world. And that is, to me, kind of a shocking statistic in a country that's supposed to be as progressive as we are. We incarcerate more people than China and Russia. However, most of the people who are in the criminal legal system are under supervision but remain in the community, about 65 to 70% of those people. So while we have a good number of people that are in a penal institution like prison and jail, the vast majority of the people are in the community and being supervised, which means they have access to all the things that anyone has in the community, including drugs, alcohol, and tobacco. We see that there's very high rates of smoking in the criminal legal system. About 70% of people in prison and smoke cigarettes. And when you think about the sheer number of people that we incarcerate and how the high rates of smoking in that population, that represents about 5% of all people who smoke. And again, for a population that probably most people don't think about too much, that's a pretty high number. And there have been very few interventions that have been tested with this population. So my first, again, experience in working with people in the prison system, I was already working in that system. And during my time there, they ended up putting in a smoking ban in the facility that I was at. And it provided an opportunity to really be able to look at what happens when you ban smoking in a prison system. And to my knowledge, it's still one of the few studies that have actually examined this, both prior to when the smoking ban was implemented until right afterwards. So we looked at we did a sort of naturalistic withdrawal in smoking behavior when the prison that I was working at went smoke-free. So we surveyed about 219 smokers about their smoking behavior, withdrawal, craving, also about their policy, about the agreement with the policy, both one week before the ban, 4 to 7 days after the ban to coincide with what I thought would be the peak of withdrawal symptoms, and then 1 month post-ban. So one of the more interesting and unexpected findings was that almost all of them, 76%, continued to smoke at some level after the ban. And I guess I should have figured that out or knew that beforehand. And they were, getting cigarettes. A lot of them had hidden them around the facility, but they also getting them through contraband channels, such as the guards bringing them in and selling them, or other ways of getting it. But we did notice too that the people who continued to smoke had all the similar sort of predictors as in the general population. They had higher rates of nicotine dependence. They were less interested in quitting smoking, higher nicotine withdrawal after the ban, higher cravings, higher overall distress as measured on the CESD. So again, the findings, I think, indicated that smoking bans had poor compliance and implementation as a policy, and that continuing to smoke was the norm and was also associated with those standard predictors of unsuccessful cessation. But to me, it also suggested the need for standard behavioral and pharmacotherapy interventions with this population. I just want to indicate this is my my dissertation advisor, Dr. Jean Christeller. So then I went on to write a K award with the mentorship of two people, Dr. Debbie Haller and Maxine Stitzer, who you can see here. So this was a project where we gave, we randomized people to either group psychotherapy, women in prison, or a waitlist control, because we wanted to give everyone the best intervention. We didn't want to give somebody, a group of people, a substandard intervention. So we delivered 10 group sessions of Sharon Hall's mood management for smoking to about 250 people, 250 women in prison. And this intervention is a CBT-based intervention focused on the management of distress, withdrawal, and other factors associated with smoking. And we thought that this would be a good intervention because we know that women in prison and men in prison as well have high rates of depression and other mood disorders. This intervention itself that includes strategies such as connecting thoughts, moods, situational triggers, and smoking behavior using monitoring tools. And we randomized, again, people to either this intervention with nicotine replacement. So we gave people patches for 12 weeks or the waitlist control. After 6 months, then they crossed over to the active intervention. The groups were about 90-minute groups, and we started the nicotine patches in week 3 and had them make a quit attempt between weeks 3 and 4. And then we got collected data at baseline, and then we had our weekly sessions at our end of treatment. I'm sorry, end of treatment was 10 weeks, not 12 weeks. And then 1 month, 3, 6, and 12-month follow-up points. So this is what we found. As you expect, when you give people nothing, they do nothing. And when you give people an intervention, they you can see the nice rise in smoking cessation rates here. Now, one of the things we were interested in looking at too was what was associated with people who became abstinent versus not. And you can see that our abstinence rates were really associated with attending different sessions, attending most of the sessions, medication compliance. We also adjusted medication compliance because if you weren't coming to the sessions, you didn't get your nicotine replacement patches. So, we did an adjustment to that to only include the people who actually were showing up for their sessions as part of that. But all of these predictors are significant with cessation. Also, again, you can see it biweekly too. So I think this really, to us, suggested the importance of adherence to both behavioral counseling and NRT. So we wanted to take a deeper dive into it and see what were the things that were associated with being adherent to both the counseling as well as the NRT, and both together. And interestingly, we found that a prior history of substance use treatment in a group format like this was significantly associated with attending behavioral counseling, which kind of makes sense. They'd already kind of experienced groups, so they knew it could be helpful, which was a good thing. In terms of adherence to using NRT, we found being white, having a high school or higher education, and higher number of prior quit attempts being associated with 80% or higher adherence. And then when you look at both together, again, the similar predictors of white, higher education, number of prior quit attempts, but then older age was associated with attendance and taking NRT, highest prior cigarettes per day, higher FTND. Maybe it's because they realize they're more dependent and they need more help to then quit. And then higher baseline cigarettes per day, which of course is correlated with FTND. When you put these into a model, you can see that with behavioral counseling, it was age of smoking initiation, baseline cigarettes per day, and prior substance use treatment were all significantly associated with adherence. Whereas with nicotine patches, we didn't see anything that came out as independently significant. For both, it was number of prior quit attempts. So again, that sort of suggests the importance of trying to make a quit attempt as being important for successful cessation. So this led to our next project. And at this point, I wrote an R01. And so this was funded by NCI. And what we were really interested in looking at is racial differences in smoking cessation, and wanted to really try and factor out, could counseling really improve those cessation rates when you give everyone bupropion? And this is in a community corrections population, so out of prison and into the community. And it was both men and women. And so we screened over 1,000 people and ended up randomizing 500 people to either just bupropion alone or 4 sessions of 30-minute counseling sessions, again, using sort of behavioral techniques for smoking cessation. And again, some of the rationale is that we wanted to keep the counseling short, because one of the things we noticed is that we had some attrition out of our counseling groups before. 10 groups is a lot. Group format is really difficult to do in the community. In prison, it's not bad to do because everyone is there. But in the community, there's all sorts of things like transportation issues and other problems that make it difficult for people to attend. So these were individual counseling sessions rather than group. And you can see, again, our baseline characteristics and randomization worked, which is good. Yeah. Okay, let me make sure I'm okay. So then you can see that, again, randomization worked pretty well here in the smoking characteristics as well. So for the demographics, all the demographics were not significantly different. But here you can see the smoking characteristics were very similar between the two groups, except that people who received counseling had higher cigarettes per day. They were less interested in quitting smoking and reported higher levels of absent self-efficacy. And then if you look at this last one, which I highlighted here, as you can see across time, this is not a baseline difference. This is an across time difference. You can see that lower rates of adherence to bupropion was associated with being in the no counseling condition. I'm sorry, in the counseling condition, sorry, lower rates of bupropion adherence. And again, that was an unusual finding. I thought, oh, well, counseling should help people take their medication. But I also do wonder if people, when they're receiving counseling, feel like that's enough. I don't need to take this medication too. So I haven't really been able to really tease out why that was the case. But you can see it was quite impactful when you look at the racial racial differences in our groups. So when you control for these significant covariates that I mentioned, the baseline cigarettes per day, efficacy and adherence, we found a significant interaction for treatment and race in quitting in absence across time, with African Americans who received no counseling had the highest quit rates, and white individuals who received no counseling had the lowest. So again, I think because most of our studies have been done in majority white populations, we tend to think of as counseling as being most effective when delivered with pharmacotherapy. But we found, again, there's a group effect, a racial effect with this. Now, when you look at medication adherence and how that relates to quit rates for both race and treatment groups, so kind of this three-way interaction, overall, African Americans had the best adherence, with 47.6% demonstrating taking 80% or more of their bupropion doses and being adherent, whereas whites had a lower rate of adherence, about 37%. The people who were just given that no counseling or brief advice group had about 49% adherence versus 39% in the counseling groups. So again, we found significant differences in race and treatment group for adherence, with African Americans with no counseling having the highest adherence at, again, 53%, followed by African Americans who received counseling with 43%, and whites with no counseling 42%, and then whites with received counseling having, again, the lowest. So again, we found a significant three-way interaction, which is what this is showing you here, between race, treatment group, and medication adherence, such as African Americans who received no counseling were the most adherent, followed by African Americans who had counseling. And whites who had counseling were more likely to be adherent to bupropion. So again, these sort of flipped as what you might expect. And then all our non-adherent groups had very low quit rates. So with this information, we wanted to try and develop an intervention that would really try to target adherence, because medication adherence has been very important for people to quit. And there are very few interventions that have been developed that have been successfully developed to target adherence. So most of the interventions that have been developed have been educational, telling people the importance of taking their medication, maybe helping them problem solve around taking the medication, but not really anything that's a little bit more behavioral in approach. And so that was what we wanted to do. So we know that factors associated, again, with poor adherence that are modifiable are some of these beliefs around using pharmacotherapy. So a lot of our participants think, oh, I can quit without using any pharmacotherapy. I can do it again with maybe just counseling alone. Or there's concern about side effects or adverse events with medication. Or they may lack knowledge on how to use medication. So, bupropion, varenicline, you have to take it twice a day. And gosh, what do I do if I miss my dose? Do I just double up? Again, you talk to people about that. But again, in reality, when they go home, they may not recall or may feel nervous about taking medication in general. We do know that life events, stress, and forgetting to use their medications also impact adherence. And then we know there are structural barriers such as, low finances, lack of insurance that keep people from using these medications. So in developing an intervention, I wanted to draw on kind of two things that I knew about from the literature. So exposure therapy is one of the behavioral techniques that as a clinical psychologist we use mostly around trauma and PTSD. So prolonged exposure is, a behavioral technique that we use, but then also, exposing people to feared circumstances, events is also part of that. And we know that when you put people in situations that are normally benign for most of us, like being in a room like this, if with someone with trauma, with people that they don't know, it could be very nerve-wracking for them and be very anxiety provoking. Or sitting with your back to somebody is also another thing that, for people, that exposure can really help bring down that anxiety. And in thinking about it, we were wondering, how about medication? Are people feeling like, I don't want to take this medication because I'm afraid of what might happen, the bad effects that I might have. So could we put medication, have people use it in session to then have them be able to see that, look, nothing bad happens when we use this medication. So that's what we did. And then the idea of practice quit attempts, which has been something that my colleague Matt Carpenter has done a lot of work around, and others now, where you have it's a low threat introduction to using medication and quitting, where you tell people, listen, we just want you to try the medication, see what you learn about it. You can try to make a quit attempt. You can use it in situations where you normally can't smoke, but using these two techniques together in this intervention. So develop this, what we call the in vivo smoking cessation intervention, to try and expose people to NRT in session, followed by practice quit attempts between sessions. So here's what this looks like. So the in vivo intervention is on top here. So you put the patch on them. They come into your office. You have them put the patch on. You instruct them on how to use it, like where to put it. And before they put it on, you have them answer questions about withdrawal and craving. They put the patch on, and then they fill out the rest of their survey instruments. And then after that, you explore what they notice about wearing the patch. So maybe for people, they'll say, my arm is itching where I put that patch. And, you say, well, that's kind of normal. Some people do get a little itchy. What you're going to do is, tomorrow you'll take that patch off and you'll put a new one on the opposite arm. Or you can use a little hydrocortisone cream on it after you take it off. It's normal as long as, it doesn't get red outside the arm, outside the area of the patch, you're fine. But I think if someone was at home and trying that, they might think, oh my gosh, I'm having an allergic reaction. Let me pull that patch off. I must be allergic to it and I won't ever use it again. So again, it's this idea of being able to address in real time people's concerns and their experiences that they're having with using these products. You can also, correct them if they go to put it, on their leg or something. You say, no, we put it up in the t-shirt area on our body, right? So again, some education as well. So then we give them a week's worth of patches and they go home and they try to make practice quit attempts with the patches. In session 2, they come in and a similar thing, but with the lozenge. You have them fill out the craving and withdrawal measures beforehand, then you have them use the lozenge in session. Again, you instruct them on it. Don't chew the lozenge and swallow it. That's going to make you nauseated, right? But again, if they did this at home and they didn't know or they forgot what you told them, they might think, oh, I'm having an adverse reaction. I'm like vomiting or I'm getting nauseated from the lozenge. So again, it gives you an opportunity to really address these in real time. And the whole point of showing craving and withdrawal pre and post, we share that with them in session to show people, look, you have the patch on. This is what your withdrawal was at before. Now it's down to here, but notice it's not down to 0. So guess what? That means you have some work to do in your, in coming up with strategies to manage withdrawal as well. Because again, I think some of the perception is that, well, I can just use this medication. It's going to do everything for me. I shouldn't have any craving or any withdrawal and I'm all done. So, and then when they have craving and withdrawal, guess what? They think the medication doesn't work, right? So it's a way of really being able to address a lot of these misperceptions in session. In session 3, again, they come in and they use both products together, NRT with the patch and lozenge. Again, showing them that it's safe. They're not going to keel over. It's, they can use the lozenge and we give them, upper ranges for that as well. We also reflect on what they learned like the previous week. So, how did it go with using the lozenge? We're able to problem solve in real time. And then at the end of session 3, we have them set a quit date before session 4 to then practice using to having a quit date. And then session 4, what we do is reflect on that using the combination NRT as well as review their problems and solutions. And then we continue to provide the medication. In the standard counseling, what we did is we gave them the pre-post measures, but then, standard cognitive behavioral therapy sort of addressing tobacco use. In session 3, we also gave them a patch and lozenge. And then they just got it in a baggie, though, just like you would if you picked up from your pharmacy, had them set a quit date, just like in the other group. And then in session 4, you focus on, the gains and relapse risk and et cetera. So these were our 2 groups. Our control group is really best standard of care for smoking cessation. And we wanted to see if we could improve adherence and thereby increase cessation. Okay, so what you see here is we did improve adherence. Our in vivo group at all the weeks had much higher rates of adherence, and you can see it was statistically significant based upon the comparisons at week 4, week 8, week 12, 1 month. And again, these are proportions. So you can see that we were at like 50 to 75% adherence versus, 30s to 50s in the standard counseling for lozenge, which lozenge is really tough because people generally don't use enough of it. And we had to talk to them about that as well. And then patch, usually patch is a little easier to use because it's a once a day, you just throw it on. But we still had higher and significantly higher rates of patch adherence in our in vivo group. And then combined was also about 10 points higher in our in vivo group versus standard counseling. And again, I think this is important because our standard counseling is the best practice. And then you can see significantly different adherence across time as well. What you see here, though, are our smoking cessation outcomes. And unfortunately, none of those were significantly different across time, except for we looked at quit attempts. And we had more quit attempts in our in vivo group than in our standard counseling group. And you can see it kind of graphically over to the right here, more quit attempts. But again, smoking abstinence, floating abstinence, cigarettes per day, none of that was really significant across time. There were a couple maybe in here that were at one time point or another that was significant, but not across time. So what do you do when you have these null results? Well, you do mediation analyses. So we did a mediation analysis to look at what might be related to our cessation outcomes. So you can see our intervention, which our in vivo group increased quit attempts, which we saw before. And you can see that was related to quitting in absence rates. And then similarly, increased quit attempts led to less cigarettes per day, which lower cigarettes per day increased abstinence rates as well. So where do we go from here? So what we're interested in doing is looking, well, we know that our in vivo group did improve our adherence rates, even if it did not improve our abstinence rates on just across time. Again, being in the in vivo group was associated with more quit attempts and abstinence in our mediational models. So what I'd like to do next is to submit a project testing this in vivo intervention and use it with more behavioral strategies to see if that does really tend to increase, give people more skills on how to resist smoking and managing withdrawal and other things to optimize both quit attempts and cessation. And then I'd also like to test this with medications. And I think varenicline would be a good one to test with. Again, have them use the medication in session, have them see what they experience within the first 30 minutes to an hour. And again, getting them to actually try the medication, I think, is really half the battle in helping people quit. So I want to turn to look at our work with smoking cessation, HIV, and people living with HIV. And, this really came out of my interest in working with this population because we know they have high rates of tobacco use, about 2 to 3 times the rates of people without HIV. And there's high rates of morbidity and mortality. If you think about the management of HIV disease, it's really been a success story. It went from back in the 80s to 90s to being a death sentence to really another chronic disease that has pretty good outcomes associated with it. So if you were to get HIV now, you would expect to live another 43 years if you got it at age 20 on medications. And that is amazing when you think about it, where people are dying in their teens, 20s, 30s after a couple of years of having HIV. But we do know that the factors associated with early viral suppression are really the social determinant of health factors. But when you look at the declines in modern day therapies with HIV, really the declines in life expectancy are all really around substance use, with tobacco, other substance use, and alcohol really being the significant driver of mortality in this population, with people who live with HIV losing an average of 12.3 years of life compared to people without HIV. And people with HIV are 10 times more likely to die from lung cancer than AIDS. So that's really, again, an amazing stat. So I think we really need to intervene with this population. So one of the benefits is that they're all engaged, the ones who are on medication are all engaged in regular clinical care. They see their doctor every 6 months. There's good programs out there with Ryan White to make sure they get their medications, and they can have their other chronic disease managed as well, all sort of in a one-stop shop for a lot of people. So how can we get doctors then to really start treating these patients for tobacco use? Because we know that's the thing that's impacting their health the most. So in medicine, we know that algorithms are routinely used to help providers optimize treatment. It's done for blood pressure, it's done for diabetes management, where you try the first line of treatment. It's done in depression. What do we try in people who are depressed? We start with SSRIs, right? And then you go to augment. First, you max the dose, and then you augment perhaps, or there are different algorithms that people use. And we know that algorithms can really help, especially people who are not experts in that area, manage that disease. And unfortunately, really very few physicians get trained on tobacco and don't consider themselves experts in substance use or tobacco treatment. And this is particularly true among internists who are now infectious disease physicians, they really don't get much exposure or much training in how to manage this. So we know that algorithms can be very effective because they standardize provision of care across both patients and providers. The best algorithms provide very clear guidance on how to treat a disorder. You start with this, then you move to this, you do this, then you do that, and you go down a sort of a decision tree or branching logic. And it has to be very feasible to implement in busy primary care settings. If you're an infectious disease physician, you're not only managing their HIV meds, but you're managing their diabetes, their hypertension, their cholesterol, maybe their psychiatric illnesses as well. So it is a busy, busy visit, right? And tobacco sort of falls at the end of the list because, it's not killing them now, but their diabetes might. So let me address that. Again, algorithms are best when these three criteria are met. There's multiple interventions for the condition. And we know that in tobacco, that is true. We have multiple medications and other interventions. The condition is chronic. We know that, people don't spontaneously generally stop smoking on their own. They continue to smoke. And the condition is one in which is often not the presenting problem, but yet is still a significant medical concern. And again, I think that's tobacco. Most people don't go in and see their primary care doctor asking for help to quit smoking. They're going in because their blood pressure is out of control or other issues. And maybe tobacco is contributing to that, but that's not what is bringing them into the office. And again, so I think this is a good place for smoking, for an algorithm in smoking cessation. Now, there have been very few algorithms that have been developed for smoking cessation, and really none of them have been empirically tested. A lot of them are just sort of suggestions. Well, if people want to quit, then give them, assist them with that, right? But if they don't want to quit, then do motivational interviewing or other kinds of motivational techniques, which is really not feasible for primary care doctors to, sit and do a motivation. First of all, they're not trained in it, and they don't have time to do that kind of counseling intervention. Also, if you're a primary care doctor, you might not know, gosh, is it safe to use varenicline? Should I start with that? Do I start with NRT? That's over the counter. They can just buy it themselves. So even if they're thinking about it, it doesn't give a lot of guidance on where to start. Also doesn't provide augmentation if your first therapy is ineffective. And then it often, again, like I mentioned, separates patients by motivation level. And if you say, hey, Joe, you need to quit smoking, your blood pressure is, sky high or whatever. And if they say, well, no, I don't really, I got a lot going on, I'm not interested in it. Then they just kind of say, okay, well, we'll talk about that maybe next time. And so nothing happens in that visit generally to address tobacco. And again, it's really not clear to me that motivation is that important. I mean, I don't know about you, but I'm not generally motivated to work out very much, right? Like I'm not waking up going, wow, I just want to go work out today. But I do it because I know it's good for my health, right? And the same thing, I think, for other chronic diseases, I think most people aren't asked when they have diabetes, are you ready to manage your diabetes? Oh, you're not? Okay, well, we'll just see you later. I mean, it's a very much a disconnect because, tobacco is what is killing people the most in our country. So I think, again, trying to provide guidance for all providers to help people quit smoking is important. So we developed this algorithm. My colleague and I, Matt Carpenter, have refined this here. But what you see if you go through this algorithm is that everyone gets treatment. Now, the only people who really only get counseling are pregnant women. But otherwise, if you're not interested in quitting smoking, you get put down an NRT pathway because you can stop and start NRT with very little consequence. And you could at least use, lozenges during times when you can't smoke or other ways. With varenicline and bupropion, because they do take a titration schedule, we bring people down this algorithm if they're interested in quitting smoking and they can commit to taking a pill twice a day. So again, I think the nice thing about this algorithm, it's very clear branching. Everyone gets an intervention, a pharmacotherapy, and ideally counseling with it. But again, this is really structured for a primary care office like HIV providers. So we didn't offer counseling with it. And that may have been a problem, which I'll show you in a minute. So what you see here, as you expect, Again, providers can still provide whatever they do normally, so they can still give medication if they want. But what we did is we had participants answer those questions on a computer tablet. It gave a recommendation to a provider, and then they were free. Then the provider got a specific recommendation: prescribe varenicline. It would tell the titration schedule. And in our latest study, we had it do a pre-filled prescription. So all you'd have to do as a provider would be press like approve, and then it would send the prescription for the person. And what you see though here, but providers didn't have to do it, and they could change. They could do, oh, I don't want to do varenicline with this person, I'm going to give them NRT instead. They could do that too. And providers who were not given this algorithm still could do whatever they do normally in clinical practice. So if they wanted to prescribe, they just weren't given the suggestion or the algorithm output. So what you see here though is you see in our pilot study, you see an increase in medication use, which is good. And you see cigarettes reducing, again, good. And then treatment as usual did get like brief advice and a brief tip sheet on how to quit smoking. So they did get something. And of course they could have gotten medication, and they can always go buy stuff over the counter if they wanted, NRT over the counter if they wanted to. So we did this first in our HIV clinic. And then we moved on, and with my collaborator, Matt Carpenter, did this project in the MUSC's HIV clinic. And we changed the design up for this study, in which we had, first, it was pharmacists that would prescribe because they were able to prescribe there. And we just gave everyone the algorithm. And so it was 60 people received the algorithm treatment, and it was a pre and post. So pre and then 3 months post-treatment. So there was no treatment control. And then what you can see here is, again, there was a medication that was recommended by the algorithm based on those questions that people answered. And what you see was that the providers generally followed the recommendations for NRT. So it was recommended in 47% for people, and 45% were given an NRT. Varenicline, it was pretty good. 38% were recommended, but 32% were given it. And bupropion with NRT, again, was a little bit lower, but still pretty good compliance by the pharmacists and following the recommendations. And of course, 10% of patients said, don't write me anything, I'm not interested. I think another key thing to acknowledge with this is these were not treatment seekers. This is all comers coming through who did this. And I think importantly, 65% did report using the medication, which again suggests that people are interested in quitting, even if they don't tell you in the office that they want to quit or that they want help with it. And you can just see here the reduction in cigarettes per day between baseline and 3 months, as well as nicotine dependence, as you might expect, as well as giving people the medication in the office did increase motivation. So again, I think it's important to note that maybe motivation is more dynamic than what we might normally think. And that by sheerly giving somebody an intervention like medication, you can improve motivation. So these two pilot trials then led to our R01 that with my collaborators at Fenway, Connell Clara and Heidi Crane at UW. So at UAB, we have what are called CFARs, Center for AIDS Research. And within these CFARs, there are CFARs across the whole country. Within the CFARs is what is called CNICS, which is the CFAR network of integrated clinical systems. It only took me like 5 years to learn these acronyms, okay? And there's about 10 of these different CNICS sites across the US. And what this means is that when people come in for treatment for their HIV, they are all getting the same patient-reported outcome measures. And then it goes into a big database with also like viral load, CD4, other adjudicated outcomes, like if someone has a heart attack, that's adjudicated and then put in there. So it's a really robust data set. What we were able to do was then to do this across these 3 sites that all give the same measures. So at Fenway, which is in Boston, and at Washington, at UW, in Seattle, and then at UAB. And then we randomized across these 3 sites to either the algorithm treatment or the treatment as usual, like we did in our pilot for UAB. And then the participants filled out the information, very similar. And again, the pharma recommendation went to the provider. And then we completed follow-ups through 6 months. And you can see here, if you notice the date that we started, July 1st, 2020, right after COVID. So great to have a grant during COVID. I'm sure many of you can relate, and especially a clinical trial that relies on people to come into the office for it. And we had a pretty slow start. And of course, we were delayed because of COVID. We had 2 no-cost extension years, but we still did not meet our target enrollment. I think one of the things we noticed after COVID, at UAB, we came very close. We had 92% of our target sample, and we're the largest clinic, so we had the largest number to enroll. Our target N was 250, we enrolled 230, so that wasn't too bad. But at UW and Fenway, both of them really struggled, and I think it's because of COVID hit those 2 areas first. Seattle and Boston were some of the biggest hotspots, and they quickly transitioned to using remote methods and seeing their patients all remotely. So it took a long time for people to get back into clinic, and I don't know that everyone's even come back into clinic. So anyway, so this was a struggle. Now, when we look at how well the medications were differences between algorithm and our treatment as usual, again, keep in mind, treatment as usual, people could just do what they wanted and as a provider. So we do see higher rates of medications dispensed. And then you can see, though, that when you look at mean cigarettes per day across time, you start to see some separation, but we were pretty underpowered to find those differences. And we've looked at it in terms of reductions in cigarettes per day, which is kind of what I'm showing you here. We looked at abstinence at any time point. We looked at floating abstinence. We looked at quit attempts. Unfortunately, no significant differences. And again, I think it's because not everyone was prescribed something, and our sample size was unfortunately low. While we saw that providers generally increased their provision of medications to patients, again, these medications were provided in routine care with patients who then needed to pick up the medication. So that may have also, people may not have picked up their medication. I think this is an important consideration. These were non-treatment seekers. They weren't necessarily looking to quit smoking that day. We didn't offer any behavioral therapy. This was just a prescription like you would get in primary care, because it was primary care. I think, again, there was inconsistent treatment provision. If you look back at here, you can see that Fenway, even with the algorithm, only about 35% of providers actually wrote a prescription, right? So they didn't really follow it. UAB did the best with almost 70% of providers who were given a prescription given a recommendation for a prescription actually did it. So again, not consistency by providers. And then we haven't really looked at adherence to the medications, and I think that's an area to look at. But again, generally underpowered, unfortunately, for this project. I'm going to end with some of the more recent work that we've been doing in sleep and circadian. And it may seem like a bit of a departure because this is more general population and people, everyone sleeps. At least I hope everyone is sleeping. And we know that, but sleep has such an impact on almost everything. I think we're learning more and more about the impact of sleep on things like blood pressure and obesity, but even on things like psychiatric symptoms. And we think it has and we know that there are significant impacts on tobacco use and other drug use. So this is my colleague, Karen Gamble. She is a basic circadian biologist. She works with mice. So working with people was a new thing. She said, well, at least working with people, you don't get bit. And I said, well, hopefully not. I mean, we'll see. No promises, though. So we are doing 2 studies where we're looking at both tobacco and opioids and looking at circadian and sleep mechanisms associated with that. I'm just going to talk about the tobacco ones right now. So we know there are racial disparities in both sleep and circadian rhythms. We see poorer sleep quality and shorter sleep duration among Black individuals compared to white. They have an earlier phase and a faster cycle of internal clock, which may indicate an earlier chronotype. So what does that mean? They can be more like what we call larks versus night owls, for example. They like to get up earlier in the morning. And a shifted diurnal cortisone slope. We do know that phase delay is associated with substance use. So again, those night owls tend to have more substance use, including increased risk of using alcohol and tobacco. But we also know, as in other studies, it's been primarily looked at in white individuals, especially when it comes to looking at substance use and tobacco in particular. So we were really interested in looking at disordered sleep and circadian dysfunction as potential mechanisms that maintain smoking behavior and dependence in Black smokers relative to whites. So again, this is just what I talked about before, but you can see across a lot of different substances, sleep impacts these substances. So this was our design here. So what we did is our first aim was enrolling both smokers and non-smokers, and it was really just surveys. We gave over 600 surveys to smokers and non-smokers, and really looking at baseline characteristics of those, both tobacco and sleep. And then what we had them do after they filled out the surveys, they wore an actigraphy watch for 8 days, and they did EMA, where we asked them questions, ecological momentary assessment, where we sent questions 4 times a week, or 4 times a day rather, asking them questions about sleep and circadian, or sleep and tobacco use. And then they came in and did we had them go home and take a home sleep test. They took equipment home, which checks for sleep apnea. And then they came in for visit 2, and they did they did an overnight where we collected dim light melatonin onset through saliva. So we keep them awake. They spit in a tube every 30 minutes. And then at visit 3, they come in and they do 2 nights of polysomnography to look at sleep architecture. And we kept them in during that whole time. So we were looking at tobacco withdrawal as well as sleep architecture, and really looking at, again, how tobacco withdrawal and craving impacts sleep. So that's the design. So I'm going to show you some of our dim light melatonin onset, or DILMO, patterns here. So this is on the left, you can see this is a normal sort of what your melatonin does in your body, hopefully normally. So in the morning, your melatonin is low, right? You're not feeling sleepy, hopefully. Maybe during this talk you are now. But then your melatonin starts to rise. And by about 8 o'clock or so, for a lot of people, you can start to catch the rise in melatonin, and then it goes up, and then you're sleeping when it's kind of at this higher level, and then it goes back down. And so then back over here, you start that kind of coming down. So this is kind of what a normal one looks like. We brought them in at 5 o'clock. We did 30 minutes every 30 minutes. And then we stopped collecting like around 3 o'clock in the morning, and they just finished out the night sleeping, and then they went home. So I showed you what the normal one looks like. This is what we got. We got all over the place, including people who came in with high levels of melatonin and kept high levels of melatonin, even though we tried to exclude people who were taking melatonin over the counter. We had people who their melatonin never rose. So these lows, and people who were just kind of started off their melatonin rose very late. So all these different patterns. So when you look at these different patterns, and you look at it by racial and smoking groups, you can see significant differences with people who smoke tending to have the low pattern, and these non-smokers were more likely to have a declining pattern. So they started high and then declined very quickly, where melatonin rises normally and then declines at the end, which is more the normal pattern. And you can see again that smokers had a later DILMO, which meant that they were more like a night owl, right? A night owl chronotype. They like to stay up late, wake up late. But we did not find a difference in their mid-sleep phase angle, which means that we did not find a discrepancy. So it's not like they were staying up late, even though their melatonin was rising. So their melatonin was naturally going up as well, along with their mid-sleep time was what you would expect with their chronotype. When you look at actigraphy, you find that smokers had a 46-minute later sleep delay, and their mid-sleep time was 37 minutes later than non-smokers. And again, with these watches, smokers had worse sleep quality, as indicated by reduced sleep efficiency. They had increased activity during sleep and increased sleep fragmentation, meaning they were waking up more and more. And that we also saw that smokers were more likely to have light exposure, perhaps due to waking up and turning on a light to have a cigarette, or perhaps just more light exposure. Maybe they sleep with the TV on or their phone next to their head or something like that. Both smokers and Black individuals were also more likely to have higher light exposure. So both smokers and Black persons had a shorter sleep duration compared to non-smokers and whites. We also did do EMA, like I mentioned, where we asked them about smoking events as well as craving and urge across time. And this is my colleague, Michael Lucinell at Oklahoma, who assisted us. We used his program, the Insight M Health app. And what you can see here, and my colleague Karen likes to call these smokograms. So this is each individual person, and you can see across the clock what their smoking rates look like and their craving and withdrawal. And you can see that generally Black smokers had fewer smoking events. Participants with shorter sleep duration tended to record more cigarettes, which means they were awake, so they were probably smoking more. And that participants with greater inner daily stability, so which is a good thing, also recorded more cigarettes. So summaries. So we identified some novel patterns of melatonin production over the course of the night. And we noticed that this melatonin is different for both smokers and non-smokers, and that participants who had these low melatonin levels were more likely to be smokers, and those with the declining pattern were more likely to be non-smokers. And we had a later DILMO and melatonin onset, but there was no difference in timing of sleep in relation to that. And then both smokers and Black individuals had shorter sleep durations and reduced sleep efficiency, reduced relative amplitude compared to non-smokers and whites. And they also had greater light exposure. So what this all suggests is that perhaps we should be developing an intervention to improve sleep via improving circadian entrainment, reducing light exposure, and this could provide some novel avenues for smoking cessation. I want to acknowledge my collaborators here. It's a lot of people who've contributed to all of this work that I just described, including people at UAB, as well as my outside collaborators. And then I want to acknowledge my funding institute, mostly NIDA, but also NIAAA. So thank you very much. Okay,
Yeah,
any
so-
questions? Yeah.
Thank you for lovely. So Rihanna, them fun up there.
Thank you for your talk, and what a wonderful range of range of topics you covered. So I'm curious about your smoking and sleep studies, whether or not you included folks who are also using e-cigarettes. And what...
Yeah, that's a great question. So we purposely excluded people who are using e-cigarettes. That's another thing we've thought about doing, is maybe doing another study where we bring in dual users or exclusive, some mixture of that as well. We tried to exclude other tobacco products generally.
Thank you.
Mm-hmm.
We have a question online. So
Oh,
Chris,
okay.
We do. It's a long one.
Okay.
Willie Tron says, earlier this year, I read an article about how the Oklahoma Department of Corrections allows prisoners to purchase flavored nicotine pouches and disposable e-cigarettes at the commissary, reversing a long-standing tobacco-free policy. The intention was to reduce contraband, violence, and tobacco use. And I would love to hear your thoughts about this policy change and how the effectiveness of the change could be measured or studied. And while the priorities seem to be contraband and violence reduction, could there be cessation opportunities available paired with the switching to potentially reduced risk nicotine products?
That's a great question. I was unaware of that policy, but that's really interesting. I mean, as we showed in our data, people continue to smoke, and there is always contraband that is brought in. So I do think it's an interesting idea. The other thing that I think is interesting too is we know that when people leave prison, and most people do leave prison, again, probably not something we think about very much. Most people do leave prison, and most of them will relapse, like 95% will relapse back to tobacco. Could getting them on a smokeless product be a harm reduction way of keeping people from relapsing? That's a really interesting idea, both inside and outside. Again, probably a place where we need more research to help us determine what would be most effective. But thank you.
Thanks for a great talk. My question for you is about one of the first studies you presented on what looked like the iatrogenic effect, where counseling appeared to reduce outcomes in African-American participants. but not in white participants. Any thoughts on what the mechanism could be there, and any counselor characteristics that could be involved there?
Yeah, so that's a great question. So we actually did look at, we collected data on looking at counselor and how well they like their counselor. What do they call that? Counselor. Anyway, how well they like the counselor, how well the counselor liked the participant as well. And we haven't unfortunately looked at that data. We probably need to. It's just, I need people to help me, write up all this data. I'm sure many of you can relate to this as well. But that would be a really important thing to look at. I also do wonder, sometimes I feel like with counseling, so much of it is an emphasis on the behavioral techniques, avoiding high risk situations, coping with withdrawal, that perhaps they felt like they don't need the medication either. Like I'm learning all these techniques. And a lot of people do want to try and be drug free and, be nicotine free or otherwise free, because they're afraid that maybe, I don't know, that somehow it's a crutch or, it's trading one addiction for another or some of these ideas. So I think, again, there's some education that could be done around that as well.
So Karen, we are out of time at this point, but I want to
Yes.
thank you for just a really wonderful, innovative, thoughtful presentation. You do great work.
Oh, well,
So-
thank you. Thank you for inviting me. Really appreciate it.